I'm going to go ahead and get started because I think the best part of this I've saved for the end, where we can all participate together and come up with a treatment plan for our friend here, who I will call G. He was diagnosed fairly early, soon after his 4th birthday. He was diagnosed with developmental delay and communication impairment. Then identified were his restricted and repetitive and stereotyped patterns of interest and activities, as well as impairment in social interactions. Therefore, he clearly met criteria for autism with moderate mental retardation. I could probably put moderate mental retardation in quotes. I think people have highlighted this morning how much difference there can be between expressive and receptive language, which makes coming up with a solid IQ number or level very difficult, which was G's case also. G had some general sleep difficulties and dependence on his family. Otherwise, he was progressing fairly well with appropriate early intervention, regional center services, and social communication support. So to start off, I'd like to ask a few questions that come up in this first part. Are many children first diagnosed with nonspecific diagnosis, such as language delay or general delay, or was this an oversight?
I think most children are diagnosed early on with a general delay, that typically the first signs people think of as a delay in language development, not necessarily what Dr. Hutman's work has pointed out as a delay in curiosity and a delay in social engagement. So yes, many are diagnosed early with something else before autism is identified.
What factors have you found from your evidence-based evaluations to identify these children more specifically as autistic, or is it still just a wait and see?
Well, we use the gold standard measures for a diagnosis, making a diagnosis, but they still have limitations. You know, as we know from the early childhood research, the children are still a moving target with the skills and abilities, but we do have measures that specifically look at what has been identified in early childhood as delays and deficits for autism, with things like the Autism Diagnostic Observation Schedule, and also getting reports and interviews across caregivers and people who actually are with the child to find out where their strengths and their weaknesses are.
Or are there neurologic issues to weigh into the equation, and how helpful are imaging studies at this point?
There are actually American Academy of Neurology and American Academy of Pediatric guidelines that were actually published in 2000, but there's a committee that is working on revising those as we speak. But basically that are practice parameters for what do you do to evaluate a child with a diagnosis of autism. And then there's separate parameters for what do you do to evaluate a child with global developmental delay. And those parameters are actually different. So for autism, the only thing that is standardly recommended is genetics. And when the parameters came out now 12 years ago, they were actually pretty general in terms of what the genetics meant. And really the assumption was that the genetics at that point meant just a basic chromosomal screening, or a karyotype as we would call it, and also screening for Fragile X. As you probably know, and Dan's going to talk about this later, over time we've been finding more and more sort of small mutations, many of which are new in the child, that are likely causative or at least implicated in some of the developmental delays. And so now we do much higher level genetic testing in these kids. But that's the only area that's really been shown to be useful across the board. So imaging, meaning MRI, EEG, and any kind of a metabolic workup are not technically recommended for every child. Of course, if there's any red flags because they have an abnormal neurologic examination or there's a concern about seizures, then of course we would obtain that. Now for a kid with global delay, so that means that they not only have language delay but also motor delay. In that subgroup of kids, so again, this is not autism now, it's global developmental delay, the AAN does recommend performing neuroimaging in the form of an MRI. And that's just been shown based on studies of what's higher yield based on the child. So.
I know a lot of these young children, one of the things that we're confronted with is sleep problems. Are sleep problems, do they present differently in children with autism? or compared to a child with maybe just general developmental delay or a genetic syndrome? Is there any characteristics between a child with autism and their sleep pattern versus someone else?
Sleep impairment is extremely common, and every time a new paper comes out, the rate is higher. But it's been reported in up to 80% of children with autism. There's a big group in Vanderbilt that's done a lot of work looking at very large population-based studies of kids with autism. The classic sleep pattern is one of insomnia, which just means not enough sleep. So insomnia can present in a variety of ways, but the classic sleep pattern that's been described both by parent questionnaires and also by actual sleep studies where you do an EEG and you look at breathing patterns and other things, is that a child has a longer sleep latency, so it takes the child longer to fall asleep. And again, that's shown by the EEG and also just again by what the parents report. Once they, and I'm sure parents in the room here I'm sure are nodding their heads because you all experience this much more than we do as clinicians, but so they take longer to fall asleep, and then once they're asleep, they have more nighttime arousal, so they wake up more often in the middle of the night. And a parent will often report, my child's happy as a clam, he just wakes up and is singing in his bed, for hours and is awake. So it's not that they're really disturbed by it, but they're awake, which is of course disruptive to the family for many reasons. And then finally the child goes back to sleep, but then has trouble waking up in the morning because they're tired. In sleep studies, we found abnormal sleep architecture, so meaning the stages of sleep that we talk about are not the same as you would see in a typically developing child. So we know that it's physiology, it's not just behavior.
One of the other questions that ran through my mind is, how about anxiety disorders? Is that something I should be looking for this early on in someone like G?
I think with anxiety, it is important to remember that it is a phenomenon that everybody experiences to a certain extent, and where you really draw the line between clinical anxiety and just normal experiences of anxiety is either whether it interferes significantly with one's quality of life or it severely limits engagement in developmentally appropriate activities. So it can be a little hard to assess the quality of life issue with a 4-year-old, but occasionally that will be obvious in terms of just a very miserable child who is really wanting to do something and they're not able to because they're scared. So that can occasionally occur. More frequently, you're going to see phobias and general avoidant behaviors at that age group that are linked with some kind of fear of threat, and whether it be threat to self or occasionally threat of some kind of more limited social consequence. But the bottom line is that phobias can be extremely impairing if they limit participation in developmentally appropriate activities like attending preschool or engaging in conversations with others. Oftentimes in autism, it's difficult to distinguish between a skill deficit, for instance, communication skills, and pure social anxiety, but it's important to be able to attend to the possible role of anxiety, particularly for older children, but it can emerge as young as age 4 in terms of a significant clinical factor in difficulty with social interactions for children with autism. You'll also see a lot of separation anxiety at this age group, and that can also have clinical implications such as being unwilling to either go to school and separate or have a babysitter and separate or even just be by oneself in a room for more than a few seconds. And so all of these patterns can be even more prominent over the course of childhood, but you can see the roots of them as early as the preschool years or even earlier. And I think the final point is that children with autism have a fairly high rate of anxiety disorders that are clinically impairing compared to the typical population, and the estimate is somewhere between 30 to 80%. And the 80% is interesting because it kind of coincides with the sleep disorder estimate, and anxiety is a very common cause of sleep problems since until the body's relaxed and comfortable, it's very difficult to get to sleep.
His primary care system involved his mother, 2 aunts, and maternal grandmother. Father was essentially not in the picture for essentially his whole life. G was very close to his family, especially his mother and grandmother. almost to a fault, because he always had difficulty separating from his mother and grandmother. He knew these two individuals could meet his needs, communicate with him easily, and most importantly, manage his behaviors. G did everything with his family and especially enjoyed taking vacations all over the world. It fit in with his repetitive interest of gathering travel brochures, maps, and the first stop on any vacation or prior to a vacation was stopping at a visitor center. Travel agents and visitor centers that he frequented knew G well. They would be sure to be well stocked with brochures before his arrival. Before the advent of the internet, technology, and I'm trying to incorporate some of the new technologies and how they weave into the picture of their limited repertoire of activities, but his perseveration and activity lent itself well to the internet, Google Map, Yahoo Map, looking at different visitor center websites, and my favorite, the Travel Channel, which he was in heaven with. These technology items occupied many of G's hours, especially in anticipation of an upcoming vacation. He became a master of the internet, iPhone, and iPad, really again putting into the question of moderate mental retardation. This interest was a highly motivating activity that was not incorporated to its fullest as a motivator. G did receive a lifetime of special services from school and regional center and was progressing as well as could be expected until his 16th birthday. So we have a few more developmental issues that are occurring within our changing world and changing environment. And you can see how his repetitive and restricted activities lent themselves well or found their way to the world of technology for him. One of the things, since G was, apart from self-injurious behaviors at times, very easy to manage, it was easy to give in to a lot of his perseverations or his likes. And so when I mention the idea of motivator, I just want to place that in your mind at this point so that you may think about what things we may do in the future as we think about this case. Now, I guess one of the things I'd like to ask, now that G is getting older, are there evidence-based treatments for anxiety for children and adolescents like G? And at what age should it be addressed?
Well, there certainly seem to be promising treatments for anxiety for children with autism. We've been doing research on this, and several other centers across the world have also been doing this type of treatment, largely with cognitive behavioral therapy methods, and I don't think that the research has come to the level where you can say it is truly evidence-based without the shadow of a doubt, but it's going in that direction, and certainly the results to date support the idea that anxiety can be significantly improved with cognitive behavioral therapy. So we have explored with pilot testing this type of treatment for children as young as age 4, but our standard age group has been 7 to 14 in our research, with seemingly good clinical results in our initial clinical trials. So that being said, I think that I would just add one thing in response to this issue of motivators. Most behavioral and cognitive behavioral treatments for children really try to select aspects of the child's daily life that are motivating to the child as a means of contingent reinforcement. And one simple way of putting that is that to earn access to these preferred activities, that some kind of systematic engagement, even in small ways, in behaviors and activities that would benefit the child to practice and rehearse and to learn for either coping with negative emotion or for developing communication skills, these two things should be linked, the practicing and the preferred activities, and that contingencies do motivate desired behaviors that can help the child become more functional and to feel better too.
At the age of 16, G lost his grandmother, one of his primary caregivers. G had a lifelong history of self-injurious behavior that I alluded to, that escalated significantly after the loss of his grandmother. G's mother could not leave his side without significant self-injurious behavior, resulting in mother's inability to work and having to manage G as the primary caretaker. G developed, unfortunately, the classic stigmata of individuals with self-injurious behavior of the face and head. His face became dysmorphic with uneven frontal bossing, cauliflower ears, scarring and swelling of cheeks and lips. He also had cuts and scarring on his fists and forearms from punching out windows, doors, and walls when overwhelmed by anxiety. Interestingly enough, he rarely hurt anyone else unless you got in his way to try and protect him. Along with the self-injurious behavior came crying, anhedonia, separation anxiety, poor frustration tolerance, distrust that others could not protect him from himself and his urges. Even though G's receptive language was always better than expressive, he would make dissatisfied guttural screams when agitated and would talk in a hypophonic voice so that mother would have to be right next to him to hear what he was saying, asking at times for granny. With the behavioral deterioration, so too did his favorite activity of traveling, adding to his frustration. I forgot to mention that G is now taller, stronger, and quicker than his mother and aunts, as well as most psych techs I know, making him very intimidating. But like I said, he rarely attacked others. In that way, he was a large teddy bear, which made him very endearing. So some other things and questions popped into my mind considering this next phase of his life. And one of the questions that I had is, I thought children with autism were in their own world. So where or how do I place this notion of a loss of grandmother? And to what degree do I think about this loss?
Kids with autism are attached to their caregivers. And so despite they just demonstrate attachment behavior that's different. So I think it's a really important message to convey to folks that this is not an unusual reaction, and it should be expected with any change in primary caregivers.
And I would maybe just add, I often get referrals in clinic for the history of a developmental regression, whatever that might be. And one of the first questions that one, as a clinician, should always ask is just that: are there any environmental stressors or changes that have happened? Because children are very attuned to their environment, and often we'll see the children will show a regression in a variety of ways. It could be as core as even language function, or more overt like behaviors when there's a significant stressor in their life, partly because that's their way of expressing, the frustration or anxiety or loss. So it's a question that I often ask before jumping to getting an EEG, because I think that, that's sort of why many times people will come to a neurologist, is that, you want to make sure it's not subclinical epilepsy. But I think getting a good history of the environment is really important.
Just a thought about self-injurious behavior. Having consulted for almost 13 years now at Lanterman Developmental Center, and seeing a lot of self-injurious behavior, there, for a period of time, had been this notion that that they would engage in the self-injurious behavior as a way of increasing endorphins and achieving some sort of high. And having seen the behavior and studied it over time, you can clearly see that that is not the case. And in fact, most of the clients with this type of behavior will try and use any sort of self-restraint or staff assistance to not hurt themselves any further. My feeling is the self-injurious behavior is not one that is egocentric and one they engage in to gain a high. And it is much more environmentally and emotionally driven as an urge. And they try very hard not to engage in that activity if they can. Let's see. The other thing about self-injurious behaviors that I've come to learn is it's not specific to autism. I see it with various different types of genetic syndromes, as well as with various levels of IQ. Obviously, the lower the IQ and the lower the communicative ability, the higher the rates of SIB can occur. So there seems to be a link between those factors, but clearly self-injurious behavior crosses all developmental disabilities, not just autism. I think, again, just to highlight that in the beginning I had talked about how the mother and grandmother and their ability to impart upon G that they could manage his behaviors was a great comfort to him. And that limited his aggressive behaviors towards himself. And you can see with the loss of the primary person, and now, after creating so much damage to himself, he's really questioning who is going to protect me now? How am I going to protect myself? G had multiple psychiatric hospitalizations, and his diagnosis eluded clinicians and treatment teams in favor of acute management of agitation with physical and chemical restraint and quick discharges without thought of precipitating factors or consideration of his clear DSM symptoms, which were now beyond general grieving. Inpatient care quickly became ineffective, and brief attempts at using high-dose neuroleptics and mood stabilizers or benzodiazepines only blunted him further. Outpatient treatment was slow and inadequate to treat his escalating picture, and in-home service providers were often frightened away. So here we have a picture where now G is confronted with what is available to him for his dangerous behavior towards himself. What used to be manageable within the family and on his own is now unmanageable, and he's running into all of the different systems of care with their limitations, and it creates the picture to continue on without quick resolution, resulting in all of the facial injury, some of which could have been probably avoided, and loss of his enjoyable activity of traveling. But one of the things I wanted to make sure is, are there any neurologic issues that need to be considered at this point with all of the self-injurious behavior being directed at his head? I didn't quite know how or what to do and to what degree to pursue a neurologic evaluation.
There's a clear trigger for his self-injurious behaviors, and he has clear, psychiatric comorbidities that are sort of building and contributing to his presentation. So, if the question is, could he have produced significant head trauma to the point that imaging is useful to make sure there isn't any kind of a bleed or other brain trauma. I think there are definitely neurologists who would, to be safe, obtain even just a head CT scan to evaluate for that, because, especially if he has limited verbal abilities, he might not be able to actually describe, symptoms of head trauma like severe headache or changes in consciousness and that sort of thing. So I don't think it would be inappropriate to obtain a head CT at this point, but there's nothing about his actual injurious behaviors per se, or his change or his decline, that would make me do anything more neurologically. And again, the issue comes up a lot in terms of, and I get asked the question all the time, if there's a history of regression, should you get an EEG? And I'll just say quickly, there are some seizure syndromes that present with developmental regression. The most classic one, which is extremely rare, is a syndrome called Landau-Kleffner syndrome, where a child is typically developing, and then around age 5 or 6, all of a sudden stops talking. So it's a severe language regression. So it's not an autistic regression. And in that setting, if you obtain an EEG, what you find is that the child is spending 80% of their sleep seizing. So they have subclinical seizures that are really just in sleep. And in those children, treating them with antiepileptics is extremely effective, and they start talking again. In my entire residency, and I trained in a place that was very high volume, I saw one kid in 5 years who actually had LKS. So it's not a common diagnosis, but it's the reason that people will refer a child to a neurologist for a question of regression. But I always emphasize that it's a language regression, not an autistic regression.
One of the other things I thought about is, the use of neuroleptics now that we have the FDA approval for irritability and autism. Shouldn't we just be satisfied with reaching for a prescription of Risperdal in this case? And would that be sufficient as an overall treatment? He's clearly got irritability. And he's autistic? Or do we need to consider this case from an entire perspective of what's going on, what's happened, where the symptomatology of his irritability is arising from? So that's one thing to think about. The other thing to think about, and I've run into this quite a bit now, is that in individuals that have deterioration for psychiatric reasons, the deterioration can be treated with psychotropics, but the behavior, even though it's lessens, can continue. And that continuation, if you think about it, in large part is now you've got to reset the whole behavioral system again. When they were acutely injuring themselves, if he wanted gummy bears from Beverly Hills Hotels, you got him gummy bears from Beverly Hills Hotel. If he wanted ice cream, you got him ice cream. If he wanted to play on the internet all day, everything was given to him. And a pattern of behavior was created. So even after you may treat the underlying psychiatric disorder, the larger treatment is actually what comes afterwards. And where does that get addressed? It definitely can't be addressed on an inpatient service. It could be addressed in the home, but is it safe enough to address in the home? But I've seen that quite frequently, and it ends up leaving clinicians feeling as if maybe I haven't treated everything, maybe I need to use more medication, and if you step back and just look at the behavior and have somebody look at what's actually happened here, what's happened is you have now reinforced that behavior so much, now you've got to go through extinguishing it, which is really a difficult task. So where do we go from here? What does G need? What is available today? So I thought that we would all brainstorm and come up with a treatment plan. I guess I could get started as a first step is clearly from getting all of the different history from a young age its progression, the deterioration, in my mind, the medication to consider was obviously a medication that would treat depression and anxiety. Anxiety had been a long-term difficulty for G, which was exacerbated now. And he had a significant loss and change in his life, which was making him very depressed. And so one of the first things I would propose is getting him started on an SSRI to address both the depression and the anxiety at this point. In this entire picture, even though he would go into the psychiatric hospitalization, it does not mean that you get psychotherapy at his level. And sometimes our clients get written off as not being able to benefit from psychotherapy, whether it be a cognitive behavioral modality, whether it be setting up a behavioral motivator system at home, something that he would be able to improve his functioning or functional level at home. And so I completely agree with you in that that was not a part of the picture till much later.
What about when you're doing the ABA and doing a mixture of CBT, and so that the medication may at some time either be decreased in doses or be faded out totally?
Absolutely. You know, one of the reasons I put in, you know, what would we do in this day and time when we're thinking about this is if I could have mustered up an entire team, if I could have created a crisis home that had a program manager that was a psychotherapist, 20 to 40 hours of ABA training and therapy, a psychiatrist who would come out on a weekly basis, a school program that would revise his IEP so that we can enter into more use of the motivators both at home and at school. I think that would, and give me 6 months. Not 3 days, not a week. Give me 6 months. And I mean, I guess I'm getting to the punchline, but that's what happened in G's case. There are 2 crisis homes in the state of California that actually mesh all of these services together over a long period of time. And that was the only thing that really helped G. And I think you summarized it well: the psychotherapy, the behaviorist, the medication, being able to take the medication away.
Concern about pain and the inability to express pain in these kids, and maybe the hyperalgesia, visceral hyperalgesia, headache, whatever, constipation, and what your experience has been in terms of methods to uncover that and treat that as the cause, you know, and sort of treat the cause as opposed to the symptoms.
In the crisis home, I can do that fairly well because I can ask our behaviorists to look at the pattern of behavior after a dose of Tylenol or Motrin is given. In the community, it's very subjective. It's very difficult. The bad part is in the community, you can tell the parents, hey, why don't you try this and see if it helps the behaviors. In the group home, because he's not able to verbalize that he wants something for pain, you have to emergently page his primary MD to get a verbal order, which means, you know, 2 hours later, you've got your Tylenol and are ready to give it, unfortunately. So there is a way to do it. It's just the system doesn't allow us to do it in a timely fashion sometimes. But clearly, the best way I would propose it is looking at the behavior after giving pain medication to see if there's a response.
Possible GI issues, also just the overall sensory processing and, you know, occupational therapy perspective.
That component, I would have to say, is probably one that was not well addressed. We did leave that up to the school as far as the sensory integration issues. we did try to rule out any sort of dental sensory issues or headaches or other things. He hadn't really had any change in his bowel movements or his eating habits or his appetite to consider, that there was an active GI problem at that time.
I'll just say from a sort of research standpoint, this whole issue of sort of sensory integration or sensory processing is something that is of interest to many people because of exactly what I think you guys are alluding to, and parents will say it anecdotally very often, my child doesn't feel pain, or he'll run into a wall and not even express any discomfort, or is my child different in how he or she processes pain, and on top of that, are they not able to communicate that sensation of either hyper or hypoanalgesia, if you will. And so it's an area, and you can actually look at this at some level with EEG because you can look at how an individual processes different sort of stimuli that might replicate pain, not meaning that they feel pain, but that they see something that they would equate with being painful or unpleasant. And what's interesting is in the limited studies that have been done, we don't actually find that kids with autism as a whole at baseline process sensory stimuli differently. But again, that's like saying, there's so much heterogeneity there that it might be that there are a subgroup of kids who really do, process real tactile stimuli differently. And because they can't communicate that difference, it comes out in self-injurious behaviors, because we do know that kids, the more limited you are in your language ability, the more likely you are to have self-injurious behaviors. Connie and I see these kids, the kids who have limited verbal repertoires in her studies, and these kids have a lot of repetitive and self-injurious behaviors. They need, exactly. So what they need is sort of twofold. They need, most importantly, a way to communicate, right? To show, to be able to express themselves. Sometimes short term, we'll use a medication as kind of a Band-Aid to sort of move them along. But absolutely, what you need is to fix the root of the problem, not, again, to use a medication as a Band-Aid. The kids, over time, as they gain communication abilities or some capacity, some vehicle by which they can communicate, their repetitive behaviors go down, their self-injurious behaviors go down, and often their anxiety goes down.
One of the things that I think to me is striking is that actually G's overall quality of life and his environmental kind of pleasures have decreased rapidly over time. And so I would think that while appreciating a medical framework or the standpoint of really looking at sort of some internal physiology, I would also encourage everyone to try to think about how can we get some of those passions of his life back, his relationships with not only his immediate family, but others, as we've talked about those social networks.
Yeah, and I will say what in the crisis home, what happened is basically everything was stripped away and then slowly reintegrated using motivators and behavioral approach. And I think at this point, if I'm correct, he's in Puerto Vallarta with his little brochures on the beach when I last talked to Mom.
But my concern too is, I hate to say it, is how we failed him early on, in the sense of, I never heard that we really taught him a very consistent communication system. Coping strategies that you alluded to, that he had SIBs early on, but they were never really addressed, so that, yes, when adolescent hit, along with his primary caretaker passing away, everything, basically blew up on it.
Yeah, I think that decompensation really highlighted how much communication that family was providing for him. But yeah, the world wasn't communicating with him.
I really think the GI issues need to be addressed more. I have a 3.5-year-old son who's been diagnosed with autism, and after he poops, he's fine. When I speak to his physician about saying, can you do a complete GI workup on my son, I'm consistently being denied. Oh, he's fine, he's a normal kid, he's developing okay, his height's good. But the fact of the matter is, my son can't come tell me, Mommy, I have a tummy ache, because he's not verbal. And I've noticed that somebody else said the enjoyable activities do definitely help him with decreasing the anxiety type of behavior.
And I agree. I do the same thing. I just treat it. If rather than the workup, if I can just treat it and see if it helps, I'll just do it.
by definition, children with autism have an impairment in their language abilities. It might be extreme or might not be, but if we can't provide them with a way to communicate whatever it is they're experiencing, we see kids decline so extremely. And so I think, again, it could be GI, it could be something else, but it's the outlet that we really sort of need to work to provide them with.
We'll be here if you want to cut into your